I'm just standing here to say thank you for coming. As the airlines say, we know you have a choice of what to do with this time. We're glad you chose us. And now, Dr. La Rosa, the Vice Dean of the School of Public Health, is going to come up and speak.
Thank you, darling. I do get the privilege of introducing our distinguished Vice Dean for Global Engagement, clinical professor, and chair of the Department of Health Policy and Management in the School of Public Health. Now, I can go on and on and on, and I'm just going to give you a few of the things that Dr. Sweeney does, and then she can talk about. Now, I'm going to do it. I'm sorry, Dr. Sweeney. It is. Let's see. Her most recent position was as the Assistant Commissioner for the Bureau of HIV/AIDS Prevention and Control in the New York City Department of Health and Mental Hygiene. She is the immediate past chair of the SUNY Downstate Council, thank you very much, and served on the Presidential Advisory Council on HIV/AIDS and is president of the Medical Society of the County of Kings. She served as co-chair of the Physician Advisory Council of the New York State Department of Health AIDS Institute and as president of the Clinical Directors Network. In the fight against HIV/AIDS, Dr. Sweeney has led an incredible progress in the New York City Department of Health and Mental Hygiene prevention and control efforts, and her service on the Presidential Council and this Presidential Advisory Council on HIV/AIDS resulted in new initiatives to control the disease nationally and globally. Do you think she's maybe the person we want to listen to? Dr. Sweeney, please.
Thank you. That applause reminded me of one of the candidates, but I don't have time to talk about it. He said you loaded the room with your donors. So yesterday, February 7th, has been designated for years as National HIV/AIDS Awareness Day. That's why today, February 8th, we are going to talk about Black HIV/AIDS and other groups, but focus on the burden that HIV/AIDS has been in the Black community. As I go through the data, you'll soon become aware of why we need to have an awareness day and not just once a year. So I'm going to do a very brief overview of the history of HIV in New York City, talk about where we are now by using data about how many people became infected the last year for which we have complete data, which was in 2013. Along the way, I'm going to tell you some good news about HIV and AIDS, and then I'm going to talk about opportunities to change the epidemic to endemic. So this is the history of HIV/AIDS in New York City from 1981 to 2013. The red line at the top shows new AIDS diagnosis from 1981 when the CDC declared it a disease and an epidemic in 1981. It's July, will be 35 years. I'll show you in a later slide that people around Brooklyn knew it was an epidemic looking back before that. You can see the rise. It went very fast. There was a very fast growth in the epidemic and the number of deaths. The slide has the same shape, but fortunately didn't go as high. Now you can see that all of the lines are sloping in the right direction, going down. 2013 is not complete, but every year, fewer and fewer cases death, fewer cases are diagnosed, and that's in the environment of increased testing. We've had lots of tests here. Brooklyn Nose, some of you might know about Brooklyn Nose, and we had the Bronx Nose where we tested millions of people, and still the number of new diagnoses is going down, which is a very good sign. And if you look at the bars at the bottom that are bluish gray, those are the number of AIDS cases, because in the beginning it was only AIDS that was reported, and then in 2000, a hard-fought battle, HIV became reported. Last year in New York City, 2,832 people were diagnosed with HIV, and so that's a diagnosis rate of 33.7. Compare that to Black men whose diagnosis rate is 104 per 100,000. There were 1,784 new AIDS diagnoses. There are now 117,000, almost 118,000 people living with HIV/AIDS in New York City. It's good news for the people individually. For the epidemic, it raises additional issues because the more people that are around with the disease and feeling good and working and taking their medication, if they take their medication completely, then we have less chance of them transmitting it, but you'll see in a later slide that it doesn't always happen. The last entry on this is to show that HIV/AIDS still does kill. You see the TV commercials with everybody smiling, jumping off mountains, and painting houses, and you think that it's an innocuous disease. Many people do. I know this audience doesn't. And so people are not taking the care that they need to avoid becoming infected. The diagnosis rate here, you can see it's going in the right direction, and I just gave you that data. This is a slide that is very painful to me as a professional because between 2009 and 2013, the number of people diagnosed with HIV and AIDS at the same time has remained stubbornly at 20%. And what that means is for many years, this 20% of people that get the diagnosis at the same time, they have been able, often unknowingly, to transmit HIV to someone else because they're unaware. And all the data shows pretty much that if a person is aware of their diagnosis, they're much less likely to transmit it to someone else than for people who don't know. So it is very important for us to work on this. This is a bad news and an opportunity for us to work harder on people to make sure that they get tested. And I don't have time to go into it now, but all of us who work in healthcare, we have an opportunity in all primary care, emergency room, wherever we encounter people in the hospital to offer them an HIV test. If they haven't been tested in the past year, we should do it. Now, if somebody has a heart attack, we're gonna wait until later until they're stable. But other than that, we should be offering everyone we encounter an HIV test so that this number we can finally get down. This is by sex. You can see by the green line that, or the bars, the blue, the dark blue and the light blue, that men are more impacted by HIV than women. In the beginning, women were 1 out of 10. Now we are about a quarter of the people who are diagnosed in New York City. That's the purplish line down at the bottom. I told you that men's diagnosis was going down. However, it didn't tell the whole story because if you look at MSM, that greenish chartreuse, whatever line it is, going up there, you can see it's increasing. That's MSM below the age of 30. Their numbers are going up every year. And men who have sex with men over the age of 30, their numbers are going down. Unknown, I always say it's unknown to us because people don't choose to tell us. They know why they're infected. They don't feel comfortable sharing it, so it's called unknown. The very, very good news is that heterosexual is stable to slightly decreased, and that IDUs is way down at the bottom, and it used to be way up at the top. The number of people infected through drugs, injecting drugs, has decreased by 96%. And even though the federal government didn't give any money in New York City, we made sure we had clean needles and programs for people who were still injecting drugs and tried to use the harm reduction principle. So that's another good news. So heterosexual diagnosis, 70% of females is heterosexual and only a small percentage to drug use. This is HIV and transgender. You're gonna hear more about transgender later with another one of our speakers. And the tallest line is Manhattan, and the next to it is the yellow one is Brooklyn, and then Queens and Bronx are about the same. Altogether, all of them are responsible for about 20%, with Manhattan leading. And it's interesting because transgender women, that's people who were born on their birth certificate as a man, and then through hormones or sexual reassignment surgery, they're now women. They have a very high rate of HIV infection. If you look at transgender men who were born as women and then transgender to be men, there were only 2, one in the Bronx and one in Brooklyn. Brooklyn is never left out of anything, good, bad, or indifferent. HIV among children, this is another success story that I wished I had time to go into great depth with you. You can look all the way down toward the end, whereas there used to be 300 to 400 babies born annually with HIV. Now it's single digits. You can count on one hand the number of babies born who are HIV infected. That's on the top slide. Don't have. That's a really great success story, and I wish I could tell you how it happened. This is a few of the things that made it happen, but there are more. HIV by diagnosis by race and rate, Black, non-Hispanic at the top of the chart. Hispanic is next, and white, non-Hispanic is the green line. Asian Pacific Islanders is the purple line. And in Asian Pacific Islanders, it's almost 100% men who have sex with men. There are so few women that when I was in the Department of Health, we did not often put their information because there were so few you may be able to identify where it was. So it's almost completely an MSM disease. I just had to throw this in here to show what the social determinants of health are about. Look at poverty, the high poverty rate. The poorer you are, the more likely you are to become HIV infected. The one exception to that is Chelsea Clinton, where it's a white educated group and they have the highest prevalence in the city. There's some other dynamics going on there. But when it gets to the death rate, they have one of the lowest death rates from HIV/AIDS because when they're diagnosed, they go and get care. In the Black community and to a lesser extent the Hispanic community, there are all kinds of excuses. I don't feel sick, they're poison. Everybody remembers AZT as being poison, but AZT is one of the things that's responsible for children not dying from it now. Percentage among foreign-born, Caribbean, South America, Central America, and Africa, Europe is 8%, Caribbean is 38%. The countries, Dominican Republic is number 1, Jamaica, which is number 2, is Dominican Republic is almost double that, and then it goes down from there. Foreign-born in New York City is about 36% of the population and about 34% of HIV. Age at HIV and AIDS diagnosis and the prevalence at death, and the diagnosis is 31. The age at AIDS diagnosis is 42, and persons living with HIV, the median age is about 49, and the death is 55. This is good news. This is how many people get initiated into treatment after getting started. You can see it's going up very gradually. It's not going up as fast as we want to, but from 2009 to 2013, it's from 63% to 72%. And Brooklyn, 732 diagnoses in 2013. Only 18 people in Brooklyn, the transmission risk was drug use. And men who have sex with men accounted for 53%, and women 24% of the diagnosis. I am going to end because there's someone sitting on the front seat with a hook to pull me off, but I will just tell you that I had to put the CDC Health Impact Pyramid that affects health on there, because if you look at it from the top of the pyramid to the bottom of the pyramid, all the things that we spend most of our time working on to end this epidemic are at the top of the pyramid. That's counseling and education and clinical interventions and so forth. Now, clinical interventions are going to get a boost because if you use PrEP, and I hope most of you know about PrEP, pre-exposure prophylaxis for people who don't have mutual monogamy, who aren't abstinent, and who don't use condoms, there's pre-exposure prophylaxis. You can take a pill if you're engaging in risk behavior. You can't take it just that day. You have to be on it. And then the chances of you becoming infected is reduced by 96%. If you have a partner who's HIV infected and you're not, take the PrEP, take the pill. And there are many things that we can do, and post-exposure prophylaxis. There are many things that we can do in the prevention basket to get this epidemic under control. And what I mean by becoming endemic, right now there are 750 cases of TB approximately diagnosed in New York every year. If we got HIV down to 750, then we would call it endemic instead of an epidemic. And there's one city that has already done that, and that's San Francisco. They don't call theirs an epidemic anymore. New Yorkers are leaders in many ways. I want us to, again, become a leader the way we were with the Baby AIDS bill, the way we were with name-based reporting, and get this epidemic to be no more than that endemic. Thank you.
Thank you. That was a wonderful beginning on this and what's happened and what needs to happen in the future. Now, it is my pleasure to introduce Dr. Bizrat K. Abraham, MD, MPH. She's an infectious disease physician who recently joined the New York City Department of Health and Mental Hygiene's Bureau of HIV/AIDS Prevention and Control. She's Director of Clinical Operations and Provider Communication. She completed her MD, MPH training at Emory University and her internal medicine residency at Johns Hopkins. After residency, she joined the CDC's EIS, Epidemic Intelligence Service, something you know a little bit about, Dr. Imparato, as a disease detective within the Division of Tuberculosis Elimination. She subsequently moved to New York City in order to complete her infectious disease fellowship at Cornell, after which she stayed on as a faculty at Cornell, conducting research in health disparities with a focus on HIV-related treatment outcomes. Please join me in welcoming her.
Hello. Thank you for that lovely introduction. And I've had all sorts of technical difficulties, and so my laptop seems to have crashed. So apologies, I don't have my slides with me, though I'll send them over as soon as hopefully we get it to restart. I did have some notes, so I'll go by those. Apologies. So as Dr. Sweeney pointed out already very well, we've had over the years a tremendous reduction in the number, in the morbidity and mortality associated with HIV/AIDS. And that's in large part due to the introduction of highly active, effective antiretroviral therapy. And I actually had later on a very nice slide with all the different options for therapy that are currently out there. And then I did want to point out that our reduction in the number of perinatal transmissions has been profound. And in fact, there have been no reported cases of perinatal transmission over the past year in New York City. And that's tremendous. And unfortunately, for those people that are currently infected, there are still many barriers that they face today. And the biggest burden of disease is among MSM here in New York City, and other populations such as transgender individuals continue to be disproportionately affected. And minorities as well, particularly MSM of color, also tend to be disproportionately affected. And I was going to show an epi curve, imagine an epidemiologic curve, that essentially showed that we have had a massive reduction in the number of AIDS cases and AIDS diagnoses and AIDS-related deaths since the peak, which was in the early 90s. And that's gone down tremendously. What that's meant is that the number of people living with HIV/AIDS has gone up. And that's because the lifespan for someone who's diagnosed today if they're on therapy regularly and they take their medications as they should, their lifespan essentially begins to approximate that of an individual without HIV infection, and that's a tremendous accomplishment. And I had a nice diagram of what you might have heard as the care continuum. It used to be called a care cascade, and that is essentially a series of bars which shows at 100% the number of people presumed to be infected with HIV/AIDS. So if you have 100%, these are people that know about their diagnoses as well as those that are yet to be diagnosed. And this is based on some modeling, statistical modeling we can approximate. And in the US, there are about 1.2 million. Of those, and different groups have calculated this differently, but based on CDC's numbers, about 86% are diagnosed. Of those, 40% are in care, regularly in care. So of the 100% that are all people living with HIV/AIDS, 86% are diagnosed, 40% are in care, 37% are on therapy, and only about 30% end up being virally suppressed. So for most of you probably know, the goal of HIV therapy is to ensure that a person's viral load goes to undetectable. And if they take their medications daily, nowadays pretty much almost everyone who is infected can become undetectable. So we have the biomedical interventions available such that people can become undetectable, yet we only see 30%. Now, of course, there's a small population, 14%, that don't know about their diagnosis. So those people we address by increasing testing. So there's a lot of interventions targeted at improving testing, whether that be testing people that come through every emergency room, having primary care doctors test all their patients, and there's now guidance that everyone should be tested. Before, we used to target to groups that were more likely to be infected. For example, people that use IV drugs or inject drugs. Those people were at a higher risk to get HIV. So those were the people that we were initially targeting. Now we want to test pretty much universally, even an 80-year-old woman potentially that goes into the emergency room. But then we have this big problem among the 86%. We're still losing a lot of people, and that's the question: why are so many of our people unsuppressed? And I wanted to show you guys actually a few pictures of the current drugs that are out there. There are over 26 different antiretroviral medications that are currently available. And we've come a really long way from the time of AZT, when that was really the only drug that was available. And of those 26 also, there are more than 10 that were the older drugs that had high pill burdens, meaning you had to take a lot of medication. They had lots of side effects and had funny dosing schedules. Some you would have to take on empty stomach, some with food. So they were very complicated and very difficult to take. So back in the early 90s, those were the only ones that were available. Now we have, at least now, as of today, we have 4 FDA-approved drugs that are fixed dose combinations. That means 1 pill once a day medications that can be taken to control HIV disease. So you take 1 pill once a day, every day, and your HIV should be under good control. And that's happened really within the last year and a half. Before then, we had one pill once a day. That was ATRIPLA. Now we have 4. So that's a tremendous feat. I have 3 cases that I'm just going to briefly go through that highlight, and these are patients that I've seen in the clinic, and I've tried to change around some of the data so to preserve anonymity, and that'll hopefully demonstrate some of the challenges we have. So the first case is of a 32-year-old woman, African-American female, who was admitted to the hospital with shortness of breath. She ended up getting a chest x-ray, and further workup revealed that she had PCP pneumonia. For those of you that don't know, that's an infection that's typical among immunosuppressed patients. So if you do find someone to have PCP pneumonia, the first thing you're going to do is check an HIV test. So they did, in fact, check an HIV test. She was positive, and her CD4 count, which is a measure of how immunosuppressed she is, it's part of your white blood cells, it was very low. Below 200 actually diagnoses you as having AIDS or having an infection, such as PCP. That also is a definition for AIDS. But hers was 10, so extremely low. When we asked about her exposure history, she did report that she had sex with a male who later revealed that he was gay. And she was so her course basically over the next few years is that she went on and off therapy. When she was on therapy, she wasn't taking her medications regularly and really never became suppressed. And this was actually a woman who was college educated, and her issues her diagnosis basically put her into a depression state, and she developed also a lot of anxiety all around her diagnosis. There was also a lot of stigma in her community, so she had a fear of disclosing her diagnosis, and so really kept this to herself. No one in her family or her community was aware of her diagnosis, and she didn't, she was very traumatized. And so this sort of crippled her in managing her HIV disease. And so in this case, in each case I'm going to identify some barriers. In this case, it was her depression, anxiety, as well as the generalized fear of disclosure and stigma in her community around HIV as a disease. So the second case is of a 28-year-old Hispanic male who did identify as gay. He visited an STD clinic and was diagnosed with HIV at that point. He was also diagnosed with syphilis. He reported heavy methamphetamine use, and pretty much in terms of his course, over the next few years, he went, again, on and off ART, even had a period of incarceration. Actually, that was probably the period of time where he was most adherent to therapy during his jail time. But anyway, he came back out, and eventually his CD4 count also declined. He was diagnosed with AIDS. So in this case, the barrier for him was his ongoing substance use. Also, we think he probably had some underlying depression. And then finally, the last case is of a 51-year-old male who had schizophrenia, diagnosed back in his early 20s. He was admitted to the hospital with pneumonia, bacterial pneumonia, and subsequently found to be HIV positive. He reported living in shelters and having prolonged periods, stretches of time on the street, being essentially homeless. In terms of his course, again, he actually was not on therapy often. He would intermittently get started, but spent most of his time off of therapy. So in this case, obviously, his biggest barrier is his severe mental illness, schizophrenia. And then, of course, the unstable housing, his homelessness, made it difficult, of course, for him to manage his disease. So all of these cases, have something in common, which is that the patients that I described had disruptions in their life that prevented them from adhering to a daily medication, taking a daily medication that would control their disease. And what that brings up the point is that we have societal environmental factors as well as individual level factors that all play a role in viral load suppression. So viral load suppression doesn't happen in a vacuum, essentially. So at the societal level, there are factors, and I'll just mention them briefly because I'm out of time, issues such as, do they have insurance? With the expansion of Medicaid, not every state has reaped the benefits of this, so there are still southern states that don't have expansion of Medicaid where people living with HIV/AIDS don't have access to HIV specialists in a reasonable distance. They have limited ability to actually seek and get care. And of course, stigma plays a role, the stigma to being gay, transgender, having HIV, being of a racial minority. These are all very important and affect outcome. And then, of course, at the individual level, I think I demonstrated sort of the three big issues, which are underlying mental illness. That's one of our biggest barriers. And substance use, ongoing substance use, that's number two. And then, of course, unstable housing. So it's important when addressing the epidemic, we have the biomedical intervention to really, not cure, we're short of cure, but control everyone's disease, where we treat it like a chronic disease, like diabetes. And in fact, one could argue it's worse to have diabetes than HIV nowadays. But the reality is there are still several barriers at the societal and individual level that prevent people from getting suppressed. And so these have to be addressed through basically a lot of support services. And obviously, it would be great if we could eliminate poverty and those bigger issues. But at the minimum, supporting people through these issues, whether it be getting them into psychiatric care, helping them with harm reduction services like needle exchange, and getting them housing, stable housing. These are all critical. And I could list many other services that we need more of. Thank you.
Thank you very much, Dr. Abraham. And she's posed some very interesting challenges, questions. And when we're done with our next speaker, we are going to have a panel discussion, so be thinking of the questions that you might wish to ask. Now I have the pleasure of introducing Dr. Luis Freddy Molano, MD. He joined the Community Healthcare Network in 1989 and currently serves as Vice President of Infectious Diseases and the LGBTQ, lesbian, gay, bisexual, transgender questioning programs. He is a respected voice on HIV issues, presenting at conferences including the U.S. Conference on AIDS, Office of Population Affairs, as well as state and citywide forum. He is well published. He is a board member of the Family Planning Advocates of New York State, on the Board of Trustees of the National Association of People with AIDS, sits on the New York City HIV Planning Council Needs Assessment Committee, and has served on the New York State Prevention Planning Group and the New York State AIDS Services Delivery Consortium. He's a former member of the International AIDS Society. Dr. Molano.
Thank you very much for that introduction. And I guess for 1 second, when I first met Dr. Sweeney many years ago, the first speech that I heard from her, it was in my purse, that was in the Bronx. I always have two things that I always carry with me, an umbrella and a condom. And I was saying like, interesting. So this is something that she in a way created as a commissioner, and it's very interesting because now the DOH has the lubricant in the bags, you can put it in your purse, for the lubricant, for the condoms, and you may not see it, but in the corners, you can have the Truvada for PrEP. So this is something that you can put in your purse. And anyway, although this presentation will be focused on positive women, it is the same arm that we're doing with the negative individuals, women of transgender experience. And before, when we talk about women of transgender experience, I also want to more emphasis on men of trans experience, because somebody brought it to my attention recently, Dr. Molano, why don't you talk about HIV prevention with the trans men? Because we have a vaginal dryness. We take a lot of hormones that are causing vaginal dryness that made the vaginal area and the cervical area more susceptible, not only for HIV, but for STIs. And we kind of give that for, we just didn't pay attention, and I think that that's something that we need to keep in mind. This is a lot of words. I'll be more than glad to send it to anyone interested. Basically, when we have a program in the Bronx with the transgender women of color, at one point we start seeing a lot of STIs, and trust me, it's again the same thing today. A lot of STIs, syphilis, chlamydia, and gonorrhea, and you name it, and our transgender women of color. And what is going on? What is it? 1 month, the STIs are going up, and the next month, another one is going up. So we decided to establish an intervention that we call the Teach Back program. What the Teach Back means is we listen to them in their language. We try to get as close as we can, and then we try to do some correction plan with them. So every month, our clients will handle a group. We just offer the technical assistance on how to put the presentation together, but they will do the job and they will do the presentation on their own language, on their own terms. We don't bet anything likely. And from then, this is a very representative sample. As you know, as you can see, 52% of the majority of these people are between 30 and 39. As we know, the Latina, the African American are the most impacted for them. The picture is very similar. This is from the Bronx. It's very similar to the one that we have in Queens. Now we are trying to see what we find in Brooklyn. We have now one transgender clinic in Brooklyn. The numbers are basically the same. Recently, I went to the court with the Human Trafficking Project, and I saw something that I have not seen in ages, Kaposi sarcoma. We have 2 patients, 2 females, trans females, that came with Kaposi. And for those of you who have been working for many years, it's sad that today we have that. So what we try to do is to engage those women and see that they are really knowledgeable of the situation, that they are part of us. Some of them have never seen a doctor in 3 years, 4, 5 years. When they go to the doctor, it's the first time that they find out that they have HIV and AIDS. These are women that have sex with men. I call it survival sex. These are women that most of them are undocumented. Most of them have very poor schooling. Most of them, somebody mentioned before, the speaker before, about the housing issue. This housing issue with the transgender community is even worse. It's, you go to a landlord and you're not going to get any housing. So, one thing that is worth here to mention, because I think that sometimes we try to talk about transgender individuals as marginalized, as sex workers, all of them, but we don't look at the cause and what it is that is making them to go that way. So we started a collaboration recently with the criminal court in Queens, when rather than to send the defendants for 40, 60, 90 days in the local jails, costing more money, costing more aggravation and more trauma on the patient, they will send it to us for medical care or intervention with the groups. And out of the first 10 group that they went to the courthouse, around 40 women, 27 stayed with us. We had around 9 that were HIV positive and have no idea that they were HIV positive. They were full-blown cases of AIDS. And that's to tell you just how little we count on them. We did some focus groups on when we were talking about with PrEP. And one of the patients' clients said to stand up and said, I had been in the sex trade business for 5 years and a sex services provider. And many of my colleagues in my field would love to have this information about PrEP. Why aren't you doing something? And if you look about it, think about that. That's a cruel reality, because we made all those campaigns for PEP and PrEP for us, and sometimes we ignore them. We just say, yes, another presentation on PrEP. Yes, another presentation on PEP. However, we have to think about when that patient comes to the ER, to the medical office, wherever they're coming, that they are going to have also a relation to HIV and AIDS. Recently, as of 3 weeks ago, we have a 57-year-old woman who had not had sex in 15 years. She found a boyfriend. They did the right thing. After having sex the first time, they went to one of our centers. They wanted to do the right thing. She was negative for everything. He was positive for HIV. And she has, it's another thing that we see day after day with the trans community. So right now we are expanding this trafficking program to the criminal courts in Brooklyn. In the first 3 months that we went to the Brooklyn criminal courts, we had 23 referrals. Out of those 23, 9 are positive. 2 of the 3 couples that I saw was from Brooklyn. Why, if we have such a vigorous campaign as the Brooklyn Knows campaign, and why, if we have so much information, why are we allowing for people to go without knowing their status for God knows how many years? We know that it's a long time because it's full-blown AIDS. However, we need to really think about the transgender women not as a different type of person. If I'm a person of trans experience, I don't have to go to an LGTB focus center in order to get my help. I should be able to go to your clinic, to my clinic, to any clinic in my neighborhood and get my hormones, get my HIV medications, having my treatment for diabetes, whatever is going on. I don't have to go to an LGTB. I believe totally, and maybe I'm wrong, but my premise is transgender health care is not a specialty care. It's part of primary care. So I urge everyone to keep that in consideration. When we talk about AIDS in the black community, and I see that almost all of our transgender women are either Latina or black, I have to get concerned, and you all have to get concerned, because that's at the neighbor that is living with us. We have patients who have started the transition over 15 years of age. I had somebody who told me in the Bronx, Dr. Molano, when I finish with my children, I'm going to be a trans woman. I look at this guy, very hairy, very masculine, very Latino stereotype, and I said, and I'm going to be Barbara. 5 years later, last year I go to the clinic, and I somebody waving to me. I'm Barbara. Think about the things that this individual is being exposed to as he or she goes through the transition. We got to get away from the stereotype that a trans female or a trans man looks this way or is that way. We still have individuals whose transition are very slow, weekends, and they are exposed to HIV. Without the HIV, I have been to hormone parties that they go and they change. You put your money, I put my money, 5 people pay for the $300 of hormonal. The only needle that is clean is the first one. If you bring the first one, everyone brings the clean needle, the only one clean is the first one. Everything is contaminated, hepatitis C. So right now with the program, we are trying to reach out to some of the social networks. Facebook has been wonderful for us. When the person joins the program, we tell them, listen, if you get a message, we haven't seen you, we have a party, we have this, that, it's because we need to see you, meaning that are normal. And we go over the whole protocol with them before. So we are able to post telephone numbers that always change, or you lose your number, or you lose the connection. Facebook, you log in anywhere, and you get in touch. And we update this every week, sometimes twice a week. We go to the clubs. We start a series of a network of nightclubs. You don't have to do your work at night when they go out. At the beginning with the program, that was one of the challenges. We get appointments to the transgender clients at 9, 10 in the morning. That doesn't work. They are a night population. So you're doing a cultural, organizational change within your own setting. So then you have to change the hours. And right now, we have a retention. We started with a group. This we designed like for 10 to 12 people. Right now, we have 25 people per group, twice a week, the same group, because we have so many people attending. So again, this is a lot of words in there. The teach back is basically the bottom line. Listen to what your patient is saying. Know what you want to hear. But work with the client at his or her level, not at your level. We all want what is good for our patients. Sometimes it's not the same thing. And you have to negotiate what I call the bilateral project. What the patients want in one side, what I want in one side. I'm going to leave you with a very brief one case on a patient who was living for 6 months in a cemetery, in an abandoned car. She used to clean herself with a hose. When we brought her to the clinic, we discovered that she had everything. Oh, and she was smoking pot. Of course, the provider said, we have to get her to detox, blah, blah, blah. Hey, you're living for 6 months in a cemetery, as quiet as it is. The pot is the last of my concerns. She wanted to have the hormonal, and she wants to have the surgery. Learn to negotiate with the patient on how are you going to work together. And again, teach back means listen to your patients. Thank you.
Thank you, Dr. Milano, for a very exciting and very intriguing presentation. And now, you with all your wisdom, the panelists are here. Please share your wisdom, ask your questions. Just raise your hand and let's go. And now don't be shy. The first person can do it. It's okay. It's all right. Yes, please, sir.
I have a question. I'm relatively new to Brooklyn, from upstate, small community. And in searching for a doctor here, I found that around downstate, because I work in this building, most of the doctors are not necessarily firstborn Americans. Many of them are immigrants. And when I wanted to speak to them about sexual health between gay men, I was told by 2 physicians in this neighborhood that I needed to see an infectious disease professional, that they weren't comfortable speaking about that with me. Now, as a man who's lived in a small town America for most of my life, that was very, very uncomfortable. And I thought, wait a second, I'm not talking about anything radical. So my question is, what are we as Downstate doing, or what is the city doing to reach out to, and I'm trying to put this in a gentle way, the immigrant community of physicians in this neighborhood who are seeing primarily people of color, who are not comfortable talking with gay men and women,
That's a very good question. That's a very good question.
At all. They say, I can't see you, you're a gay man. you have to go to an infectious disease. I'm here about an ear infection. What are you talking about? This is what I talk to my doctor in Oneonta about every time I visit. We go through the list of questions. So what can Downstate do, and what are we doing to reach out to the doctors that this population that's most at risk are seen? I'm not in the at most at risk population. I know that. I've been having these conversations for 20 years.
Thank you. That is very provocative and very good.
It's a very good question to start with, to which I don't have an answer. But you have really identified a really important question. But it's not just about gay sex that they have difficulty talking about. It's about sex in general. And when I worked in Bed-Stuy, I used to, when I interviewed physicians to come and work at the Bedford-Stuyvesant Family Health Center that some in the audience have heard of, I used to ask them whether or not they would be able to do that and whether they'd be willing to do that. And if they weren't, they were not a good fit for the community, because we needed to have people who would talk about sex across the life spectrum and across the various sexual orientations and so forth. I don't know what Downstate's doing, but we have a faculty development department. We'll give it to him. Is that a good idea, Dr. Imperato? Good idea. I will give it to Dr. Merlino to make sure that we start having some sensitivity training so that physicians can answer those questions. Thank you.
I would like to add. Yeah, thank you. I think.
Yes, you can have 30 seconds for this, definitely.
But I can tell you what we're doing at Downstate from the student education point of view. National averages show that less than 5 hours in the curriculum is spent on GLBTQ health. Less than 5 hours. And usually that's in the clinical years and not in the foundation years. Downstate is actually probably spending more than that in the basic science years. For example, I teach the introduction to GLBT health, and it's exactly about knowing that patients come to you who might be GLBTQ also can have earaches. But we also go into what the specifics are that their health might be more susceptible to. And we don't know the answers necessarily to all of it, but why is the cancer rate higher? Why is breast cancer higher in women? Why are anal cancers, etc.? What are the kinds of screenings you need to do in your population? So our students are getting the benefit of that training, and I hope that more and more of that will be done as well.
But I'm glad that you mentioned that the students are, but we have a lot of doctors here now who are practicing in this community and have patients that have these needs right now. And so what I was mentioning you for is so that you could do faculty development with the physicians who are providing care right now, so that they could be trained and have culture and be culturally sensitive.
That's the point. And which ones of them are actually on faculty will
Okay.
Also, Dr. Milano, you had a...
Yeah, I just want to say first, thank you for the question. The bottom line, we got to talk about sexual history, and we don't do that. And sexual history includes sexual practices. What type of sex are you having? We don't want to talk about that. With teenagers, and they have sex because they don't want to get pregnant or they lose their virginity, it's fine. We don't say anything about anal sex. With a gay man, and being a gay man myself, we go to the doctor, and the doctor will roll the eyes because here I have to deal, so I don't want to ask you have anal sex. With heterosexual couples, I guess they still have sex, but never anal sex, just the regular sex, whatever it is. We gotta get down to the dirty and say, hey, what type of sexual practices? I see right now, Federal Community Healthcare Network, we have 11 centers. We're trying to develop at least in the orientation day. They spend one day with me, and we talk about all of that. Sometimes maybe, and I have to say sometimes I went back to our CMO and said, this person is not going to work for us. I'm sorry, it's a reality. What we can do is what you did today, keep raising the issue until we get a better answer.
And I just want to add that it's not just foreign trained physicians. I think all physicians, we're all really horrible at taking a sexual history. I do hope that with the expansion of PrEP and PEP, that, that's going to be basically something that not just HIV specialists, but regular primary care doctors start prescribing. So with that, I think I hope that that'll prompt them to take a better sexual history. So.
I want to say that one of the reasons that 20% of people who get diagnosed late, HIV and AIDS at the same time, and there's a substantial number over the age of 60, is because the person goes to the doctor, the person is in their mature years, the clinician immediately assumes they're not having sex. She looks just like my grandma. My grandma wouldn't be having sex. Well, your grandma is having sex, and your mom is too, and we need to get past the idea that older people are not having sex. As a matter of fact, from the older people that I know, they say some of the best sex is when the kids are gone. And so we have to get ready to make sure that our doctors coming out of downstate understand that being 45, which is when the kids told my daughter who teaches sex education, that's when people stop having sex at 45. That's what the kids said. They're high school students, so okay. But we all have to do better because the 60-year-olds are diagnosed very often with AIDS and HIV at the same time because of the assumptions made both by the person and by the clinician.
Okay, I have one thing to say to you doctors. There are other health professionals who can also benefit from this too. As a nurse, yes, as PAs, and other folks out there, we all need to be participating in this too. Because sometimes, I don't want to talk to the doctor, but well, that nurse might be okay. Maybe I can say something to him or her. So, yes. Sir.
Hi, my name is Dr. Frank Berkeley. I'm a clinical psychologist. So that's one of the, when you're talking about that, totally hit on what I was going to hear. A lot of times the primary care physician, the psychiatrist, those folks don't have the kind of time. You're getting a diagnosis, you're saying, there's a treatment out there that's incredibly effective to suppress your viral load and eliminate nearly the risk of transmission. But you don't have the kind of time to follow up on them. What I'm hearing is your major problems or sticking points are mental health, so things like depression, substance use, treatment adherence, and these are and motivation. And these are all behavioral health issues. These are all psychology issues. Where is your integration, direct integration of psychology once somebody gets identified as HIV positive? They should immediately be offered psychological intervention just to process what that means and then work on adherence and stuff like that. And then I'll throw in, because my specialty is also telemedicine, so I've trained dozens of psychiatrists and psychologists on telemental health. How could that be used to kind of capture them immediately and transition them to ongoing care? Especially when you talk about people who, we're getting them through Facebook because their phone number is going to change frequently. But if they could have their psychological care through video, where they just have to pick up whatever phone they happen to have at the time and be able to keep that treatment going. So those kind of two issues, really leveraging psychological intervention, and then two, leveraging technology.
Thank you.
That's a great point. And actually, the HIV clinic that I worked at before, actually at Cornell, Upper East Side, which is actually a destination clinic for a lot of people from the Bronx and Harlem. Anyhow, they actually had a system of integrated care where any patient coming in for their HIV care had to see a social worker as well as a psychiatrist. And there were two designated HIV psychiatrists. There are psychiatrists that specialized in HIV populations that basically saw each of these patients. So that's a model that I think worked beautifully. And not every clinic has that model, but that's actually something I'm very interested in assessing how well integrated their clinic is with behavioral health services.
Did you say psychology? I heard social work, which is like
Psychiatry, yeah, absolutely. Not psychology. We happen to have there two psychiatrists, but it's very important. Some of the social workers are have a, what is it, C with the clinical component and can do therapy as well, but we didn't have any psychologists there.
Psychologist is the one you meet with each week.
Right.
Psychiatrist you're going to
was.
Right, right, exactly.
Okay.
One other point is we did directly observed therapy using media for tuberculosis at the Department of Health, and we were just starting a pilot when I left DOH, so for taking medication. So maybe you can resurrect that to watch people on their cell phone open their bottle and take their medication
Yes, that's a good idea.
distantly.
And
So
there are-
directly
yeah.
observed
All
therapy.
right, let's go on, and I just want to add one thing. In the School of Public Health, we do deal with this. I teach a class called Sex, Gender, Race, and Ethnicity, and this is one of the things that we talk about. Yes, some of you have been there. Ma'am, you were going to ask.
Hi, my name is Mary Grimes, and I work at the Star Clinic here at
Do you want to stand up
I
so
know
we
you
can
do.
hear you? Yeah.
No, I wanted to say something in terms of piggybacking on the age. Our oldest patient is 92.
Wow.
Yeah, and he was diagnosed at 88. And he was diagnosed in the emergency room, came in with weight loss and cervical lymphadenopathy. Now, this man has heart problems, so forth and so on, so he's been seeing his primary care provider, okay, and never ever touched HIV. This last sectional count, he was 85. So, yes, people are having sex after that. But I just wanted to, a question, because the other end of the spectrum, a young man came in last week, 23, tested positive. And this really gets to me, because this young man, you're talking about clueless. Yeah. You're talking about, I had to do HIV 00101. When I talked about modes of transmission, he had questions about drinking with his brother who's positive, blah, blah, blah. And when I explained the modes of transmission, I happened to mention breast milk transmission. And he said, well, if I rub my penis against my baby's mother's breast and some breast milk gets on it, will I get positive like that? So we're dropping the ball somewhere. You know, I don't know how, where, what can be done. Have we gone out of the schools? Are we not dealing with that anymore? I'm at a loss, because that really, it broke my heart to sit there. So I talked to him for about an hour, and it really broke my heart. So I'm just, what can we do?
Thank you.
You know, New York City's Department of Education collaborated with the Department of Health, and there's a K through 12 curriculum. However, parents, they don't get a note to sign out of calculus, but they can get a note to sign out of prevention of HIV. The prevention part of HIV, they can get a note for. And a lot of schools wanted to do abstinence only, but that was eliminated to do abstinence only. Even nationally, the amount of money being spent for abstinence only. But we have to start very early. By the time you get to high school, about a third of the kids have already had sex. So we have to start much earlier than we do to make sure that we're giving them the information.
Dr. Birnbaum.
Yeah, I'm Jeff Birnbaum, physician here at Downstate program. And I just want to defend discussing sexuality within Downstate, because the doctor does this all day long with young people. You know, I realize I'm not the only physician here in the institution, but anybody who comes through my clinic, a student, a resident, a fellow, they can't leave without acquiring these basic skills. And I'm not the only one who does it, you know, we're talking about Smart Clinic as well, where much of the conversation is centered around sexuality. I'd say here also, you know, to echo Dr. Marino's comments, there's a lot of medical student activities outside of the curriculum. There's Sex and Medicine Week. There's sexuality electives that students take. So I think the institution as a whole is addressing this head on in ways that it wasn't when I certainly went to school here months ago. And just to get back to some of the comments about, you know, people can get prep from their primary care doctors. The fact of the matter is the primary care doctors, the same way they're not talking about sex, they're not going to talk about prep. And they just say, send it to those HIV people who are just waiting to be overwhelmed by large numbers of people seeking PrEP. So I think we have a long way to go with respect to, in general, primary care providers who are already out there in practice for many years, whose habits around discussing sexuality, just that's unfortunately not going to change, or it's very difficult.
That is correct.
Well, thank you, Dr. Birnbaum. And we have other questions, I know, but it's the time to conclude this. And thank you to all.